We welcome all of you and we invite you to please share on the chat where are you joining us from. You can do it on the chat or you can also mention your name, your role, your specialty, and the place where you're working. It may be a clinic, a private practice, or organization. In a few minutes, we will be starting with today's webinar. Here we have Madame Jenny. She's joining us from Ponce, from Hogar Esperanza Unida. So thank you so much for joining us. Welcome. We have Stephanie Gonzalez from Ponce as well. Jacqueline Vázquez, she's a nutritionist. Jose Alvarado from Dorado. PRHWI, welcome. Dr. Andrea Testani. Thank you for joining us again. Very well. And since it is already 4 o'clock in the afternoon, I am going to start welcoming you, all of you, to our webinar series, uh, Multidisciplinary Approach to Chronic Conditions in Primary Care. And today we are going to be talking with our resource for today, a licensed nutritionist and dietitian, Gabriela Tirado. You can say hello to her. You can turn on your cameras if you prefer. And we are going to review our general guidelines for today. Next slide, please. Also, we want to remind you that we have this new translation services. And this is with the idea of reaching a broader audience, and you can use the services selecting on the bottom bar on your screen. You can see interpretation, and there you can click in the main room or the English channel, as you may see on the screen, and you can listen in the language that you prefer. Next slide, please. So I want to remind you that this is an initiative from the Institute of Public Health in Puerto Rico. It is from the Puerto Rico Science Research and Technology Trust, and this is learning through telemetry, and the purpose is to connect specialists with academic medical centers and providers for health in rural areas. Before we start, I want to share with you the general guidelines of our webinar series. You are welcome to turn on your camera because we want to meet you. You can type on the chat anytime during the session. You can open your microphone if you have any questions or if you have any comments. And also keep in mind that this webinar is recorded for educational purposes. We remind you that you can type your questions or comments on the chat. And here we're going to have a pre-test. And this pre-test should be popping up on your screen, but also you can find a link that will be posted on the chat very soon. Now you should be able to see on polls, you're going to see 3 questions for our pre-test. So you can answer these 3 questions. You can answer the questions and then we will be started introducing our speaker for today. You can also find the QR code on the chat. So you can use the QR code if you cannot get to the pre-test on the poll section. And here we also have our colleague, Federico Salcedo Irizarry from San Juan, Professor Norma Rosa. So thank you so much. So now we are going to continue with our speaker for today, licensed nutritionist and dietitian, Gabriela Tirado. So Gabriela, please go ahead and introduce yourself and share your screen. Welcome, Gabriela. Thank you. Allow me just a moment, please. Let me share my presentation with you. Can you see it? Now we can see it. Yes, there we go. Good afternoon, everyone. Thank you for joining us today. My name is Gabriela Tirado. I am a nutritionist and dietitian. And during this afternoon, we're going to be talking about uh, nutritional education in primary care, specifically in identifying risk and the patient's context. This webinar is a two-part series. So if you're excited and you want to learn more about nutritional education in primary care, we will see you tomorrow. And now, this afternoon, I have several objectives. But for me, the most important one is for you to recognize nutrition as a primary line intervention in primary care. And not only that, but that you may feel empowered with the necessary tools to be able to go ahead and have this intervention. But before we start, I would like to break the ice and I would like to ask you a few things. By the way, this is a disclaimer. I don't like to feel uh, alone when I am connecting digitally like this with you. So please don't hesitate to talk, interrupt me, turn on your cameras. You can type on the chat. Okay, so let's go. Okay, we have Mr. Ramon here, Don Ramon. He came to the clinic to see his physician, and the physician asked him, "Do you have any medical conditions?" And he said, "No, I am very well. I don't have any medical conditions." And then the physician is asking him if he takes any medications, and all of a sudden he has a list. And how many of you have seen this before? This is familiar for you. Let's see if I can see the chat here. Daily. Yes, myself as well. And what do you think it may be happening with those Don Ramon? What's going on every day? Okay. So for several of you, and for me as well, this is very common to see Don Ramon. But what do you think that could be going on with Don Ramon? Maybe he's not aware of all his health conditions. What else could be going on with Mr. Ramon? Please don't be afraid. Okay, if you're okay, depression, a poor insight about his conditions, a poor support, definitely Don Ramon. He's doing very well. Nothing is wrong with him. A poor education, exactly. Maybe he doesn't understand what are those medications prescribed for. Maybe he doesn't recognize hypertension and high cholesterol as medical conditions. Maybe he's disoriented. I haven't thought about that, but it may be. Oh, he's not well informed about his medical conditions. Yes. Maybe he thinks that his conditions are under control. He doesn't have them anymore. So there may be many factors, but definitely he's confused. I am listening to a microphone. What? Okay. Eating habits. Okay. So now we have this other person here, and this is Miss Juana, Doña Juana, and she's in Piñones with her daughter. He's eating alcapurria, some fritters, and her daughter is telling her she shouldn't eat that. Your cholesterol will go high. And she said, "Don't worry, I'm taking medication for that." What do you think that Doña Juana is happening with her? What do you think she's doing? Denial? It may be. What else? What else could be going on with Miss Juana? She's very happy having the other Capurria. She doesn't know about the impact of nutrition on her health. She thinks that the medication is going to help her with everything. Poor adherence, that may be as well. Yes, it could be. Here I have a few answers. Maybe she understands that the medication are canceling the impact of her uh, nutrition. She doesn't understand the role of nutrition in her treatment, or maybe she has received conflicting messages. Maybe not necessarily health professionals, but maybe she heard that around and she's repeating it. Well, eating habits are the foundation of the treatment of any chronic condition. And I love this slide because we can see how this structure, this temple, where the foundation, it says lifestyle modification. And in this case, diabetes education, but it may be any other chronic condition. The pillars that are supporting the roof then are the management of those conditions associated to diabetes, but also medical treatment. And we can see that the patient is celebrated on top because the patient has achieved their goals and they have a better quality of life. But let's see. Why is this so important? Why is it so important to talk about nutrition in primary care? Well, nutrition has a direct impact on health. And this study done by Lancet, they took into consideration 195 countries and the frequency of intaking certain nutritions and the impact that it had in mortality and the causes of death for these people who had these eating habits. And we can see that definitely diet rich in sodium, low in whole grains, fruits, nuts, seeds, it had an impact, a significant impact in the mortality of these patients. So nutrition is key for our health. Not only that, nutrition is a cost-effective nutrition, and it helps us to control and prevent chronic diseases. In addition to that, maybe there are nutritionists, but it is always good to repeat those conditions, behaviors that the patient should have, because maybe, as we have seen with Doña Juana, maybe she didn't understand something, and it's good to repeat it and have brief interventions that may lead them to behavioral changes. But mortality is not everything. Lancet also studied what we call DALI is dailies. And they compute the years of life affected by disability. And even though they discovered that in 2017, 11 million people passed away due to dietary risk, many more millions live with chronic diseases, and altogether, they lost 255 million years of healthy life. And again, when we see the chart, they were diet low in whole grains, high in sodium, low in fruits, low in nuts and seeds, and diet low in vegetables. And what do you think about this? Yes, we have people who are living, but they are not doing well. They are not living well. And in those 195 countries, Puerto Rico was not in, but for us it is important because when we see the prevalence of cardiometabolic diseases, they are increasing. Obesity, diabetes, high cholesterol, hypertension. Therefore, the diet that has such an important impact in these conditions is really important. It is critical. Lancet did another research, and it was very recent. It was published, I think it was just a few months ago, and they found that these cardiometabolic conditions are progressive. One takes to the other. And as the patient is getting more complication, the mortality risk increases. And when we see the main causes of death in Puerto Rico, again, we can see cardiometabolic diseases as one of the most important. So who think it's important to talk about nutrition in primary care? Maybe some hearts. No, it is not so important. It is really important. Thank you. It should always be included. Yes, it's really important. Thank you. Yes. It's so good that I convinced you if you were not convinced yet. And well, it is not only the aspect of nutrition per se, but it's important. It's in primary care. Is also the physician many times. That is who is the first contact about these topics with the patient, and they do more follow-up. And not only that, but in Puerto Rico, we have the virtue that 92.5% of the population has some healthcare coverage. However, 60% of the population, what they have is a vital plan or Medicare, and they cover in terms of the nutritionist, morbid obesity, and they take into consideration morbid obesity, a BMI of 35, uh, type 1 and type 2 diabetes, and all the diseases related to the kidneys. So it may be that the physician may be the only person who talks about nutrition to their patients. Maria, thank you so much. Yes, that's the foundation of health. So we have a huge problem. There is a high prevalence of cardiometabolic diseases. And there is less time because we know that in Puerto Rico, definitely the medical system is overwhelmed. And there is a lack of tools for structured counseling. But together with the Science Trust, we have prepared a set of tools to help physicians to be able to evaluate their patients in terms of nutritional risk regarding cardiometabolic health. We have a questionnaire. We have a brief initial evaluation, and this evaluation is guiding the physician to get to that intervention. And within this, we also give some cues to the physician about what they could talk about with the patient and what goals they could establish to improve their eating habits. But if the physician doesn't want to use these tools because maybe it's a lot of paperwork, we also have a decision flow chart that could help without necessarily filling out all this paperwork. And they could help to establish goals with their patients. We have a follow-up form because we need to have that follow-up. This is the foundation of health, as Mariela Lebron mentioned. So we cannot leave it just as a goal that we established a month ago and it stayed there. The patient needs to understand the importance of this change in their life. On the other hand, we have a basic educational sheet so the patient can write down the goal that they established together with the physician. And in addition, they have a context of their medical condition and what things maybe they should increase or decrease. And additionally, we have some posters that are adapted to the culture in Puerto Rico. We have a lot of material that is coming from the United States and they're wonderful, but maybe we don't identify ourselves in that material. Once this presentation is uploaded, you will have access to all these documents. So how can we use these tools? Well, the patient comes in, the administrative staff gives them the questionnaire, they fill it out, The nurse then takes the anthropometric data, they calculate the BMI, and they could identify what are those rangers who put them in risk within that questionnaire. And once they see the physician then could validate the information, and they may have a conversation with the patient and negotiate what things they could change within their eating habits with some more smart goals. We need to measure the level of trust in the patient and to educate them about why we want to set these smart goals. And we have a follow-up because we need to follow up those goals that are established with the patient, and then the patient goes home. They have their document with the written goals so they don't forget. What do you think about these tools? So the first thing is to identify if there's any nutritional risk. In this case, we are going to focus on the cardiometabolic risks, and we need to evaluate the anthropometric data, the vital signs, the laboratory markers, and the eating habits. In anthropometry, a number that is so important is the BMI. So good, Martinez. I am happy that you find it useful. The BMI, it is calculated taking the weight in kilograms and divided by the height in square inches. And we could use uh, the pounds multiplied by 703 and divided by the square inches. The previous, using the kilograms is square meters. But why is it important to take into consideration the BMI? Well, a high BMI is associated with cardiometabolic diseases. Additionally, it's what's used by the medical health insurance to validate intervention, treatment, risk, and diagnosis. As I mentioned before, it is important sometimes the number of patients limits the time that we can see the physician, and this information is so valuable. Well, BMI is not the standard for everyone. We need to take into consideration the age of the patient, because when we have older adults, a low BMI, it could put us in risk. Therefore, we are not going to measure using the same standard people who are 65 and older. We are talking about a BMI from 22 to 27 is appropriate for an older adult, 65 and older. So if Mr. Ramon comes in with a BMI of 27, we are not going to ask them to lose weight. But I am introducing Eduardo. If you take a look at Eduardo, could you identify a risk factor, a cardiometabolic risk factor? Take a look. Take a good look at him. I don't know if you can see him clearly. You can zoom in the image. Yes, I think that he is totally healthy. Totally healthy. Yes. Does anyone think different? He has a BMI of 30. He's a young person, a high muscle mass. The BMI, uh, with the BMI, we could identify the nutritional needs and to prevent cardiometabolic diseases. Well, he looks athletic. It is muscle mass. Okay, let's talk about that, because even though the BMI, because of the BMI, we could say that he's not healthy, but the fat content could say that no, Rose, Rose, exactly that. The BMI doesn't distinguish between fat and body mass and muscle mass. So now I am introducing this other patient. You could identify any cardiometabolic risk in her. Take a good look at her. Take into consideration. Read the information. It says that she has a BMI of 35. This is a mistake. She is not type 1 obesity, unintentional weight loss, exactly. Abdominal fat, an elevated BMI, waist circumference. Yes, she does have certain factors for cardiometabolic risk. But this is something really important. It's that the BMI, it's a starting point, but it is not the whole story. It does not distinguish about muscle mass, about central adiposity, as it was mentioned on the chat. It doesn't identify any fluid retention. It doesn't tell us if the person is pregnant. It doesn't take into consideration if there is weight loss. And in the latest case, she had a significant weight loss, and it was unintentional. So that is also a risk. And it is a major risk, even greater than her obesity. If a person has lost more than 5% in the past 6 to 12 months unintentionally, it may be a sign of an hidden disease. And what diseases could you think about? And think not only about her, but think about other patients, maybe an old man. What do you think? It may be cancer, yes. Diabetes, heart failure, cancer, yes. And very uncontrolled diabetes, definitely. Dementia, definitely. Maybe they are forgetting about eating, kidney disease, depression, hypothyroidism, malnutrition, thyroid problems, exactly. And I am going to add another one, issues when swallowing. There are people who start having swallowing problems and they are fearful of eating. So these people who are losing weight unintentionally, they could suffer from malnutrition, losing muscle mass, and frequent falls because of that loss in muscle mass, sarcopenia. Very well, Maria Lebron. So within our questionnaire and in our flowchart, as a priority, we need to learn about this because, as we mentioned before, weight is not everything and it is not the whole story. So now I am introducing Anna. Anna, she has a BMI of 22. Oh, I didn't talk about Eduardo. Eduardo has a lot of muscle mass, so his BMI, even though it said that he was obese, he doesn't have any cardiometabolic risk. Perfect. So let's talk about Anna. Anna has a BMI of 22 and a waist of 31.5 inches. Can you detect on her any cardiometabolic risk factor? No? Yes? Maybe? Yes. Okay, Norma says yes. Norma, talk to us. What do you think? What do you see in her? What did you notice? Okay, Valery says no, that Anna is doing very well. The measurement of her waist. Maria says no. Marianne. Julia says that her waist is over 30. Definitely, the waist number is a little bit high. And Anna is what we classify as a toffee. Thin outside, fat inside. And that waist measurement places her at risk for cardiometabolic risk. So weight is not everything. So we need to see the composition and where that fat is located in our patients. And there are many ways of measuring the fat percent as well as the concentration of fat in the central area. But the most affordable and the fastest would be the abdominal circumference, which only takes into consideration one measure. And we also have the bioimpedance balances that are affordable and non-invasive. And well, we can see here, I don't know if you notice, that women are classified as overweight when they have a fat percentage over 30, and for men over 20%. And in obesity, over 35 for women and over 25 in men. But we don't need to wait to get to that obesity range when we can already see that we have a fat percentage in 30 in the case for women and 20 for men is a cardiometabolic risk that we could address beforehand. The same way, the waist, that circumference, abdominal circumference, is going to be important in women. They already presenting risk, 31.5 inches, and for men, 37 inches or over. To take this measurement, we're going to identify the last rib, the border of the iliac crest, and in the middle point, that's where we want to be to take that measure.
What about the labs and the vital signs? Here, we're going to notice that all of the guidelines from important institutions, such as the American Heart Association, I forgot it's AACE, endocrinologist, American Association of American Endocrinologists, and the talk about the lifestyle therapy and healthy behaviors as the main therapy for the patient, regardless of where they are. That is the first tool that is available to us throughout the whole development of that condition that deals with cardiometabolic. So this is very important for the patient. In terms of the labs, we can identify that a glucose over 100 is in risk if you have pre-diabetes, more than 125, and if you are a diabetic, more than 126. If it's something that is controlled, that we don't have, it has to be more than 126. And the same thing with the A1C. We don't have to wait for it to be in 6.4. Even in 5.7, we have to start educating the patient. And it's very curious to talk about the LDL. That's an issue because we tell them that it shouldn't go over what? It shouldn't be higher than what? It should be lower than 100. However, the American Heart Association tells us that if there are cardiovascular diseases or conditions, then we have to consider that it should be less than 70. There's an adjustment that is even stricter. In the case of triglycerides, We don't have to wait for it to be at 150 when it's at 135, especially if the patient is a diabetic. We have to deal with that with education and changes in lifestyle. And in the case of the uh, blood pressure, we don't have to wait for it to be high. We have to, if there's a cardiovascular disease, we have to say, you know what, 123 is more than enough to have us talk about the ingestion of sodium. So these are some of the labs that bring to me or rise my curiosity because it's not what we find in the guidelines when we get the labs. And patients look at their lab work and they think, oh, I'm okay. They don't recognize the risk that are in the parameters included in their labs. And some other labs that we need to check are creatinine, EGFR, and the hepatic. So we don't have to wait for fatty liver. When we see the enzymes that are high, we need to start talking to that patient about changes in their lifestyle and their eating habits. We know that this is very important in this issue, and we need to evaluate them. But as we've said, doctors don't have the time, and there are certain tools, uh, surveys that you can use that are validated that can use 2 questions, up to 14 questions, and a simple question such as, listen, are you eating vegetables and fruits? That's enough. That already shows if you don't eat fruits and vegetables, you can see there already a risk. And it can be adjusted. And you can use these tools and adjust them and apply them and use them in your clinical practice. And we need to see the frequency of consumption of food. What are the impactful patterns? It allows us to start a conversation with our patients. Sometimes when we look at somebody like Anna, it looks like nothing's wrong, but we need to evaluate why she's accumulating so much fat in that particular area, in the abdominal area. Maybe she needs exercise. Maybe she's eating things that she shouldn't eat. But we can also identify favorable patterns. Maybe there are people that are doing something really right. And maybe it has nothing to do with the quality of the food, and we need to explore what other things are going on. And of course, it leads the patient to reflect, and it takes less time because it can be self-administered by the patient. And this questionnaire that we prepared helps us to identify if the patient has a eating pattern that is basic and it's color coded here, but for the patient is not going to be color coded because we don't want to insinuate that they should answer the green. We want them to truly reflect on this and answer the truth. And we can identify if if they're eating 2 portions of fruits, 3 portions of vegetables a day, if they're using uh, rich fiber products, if what they're eating is, for example, in their protein area is from fish or from meat. And so this is helpful for our evaluation. On the other hand, it can help us to identify if they have healthy patterns in their eating habits. If they're following, I see here that there is a mention of the Mediterranean diet and DASH. And it is curious that you mentioned that in the chat and the American Heart Association because it is a diet pattern that is also required in other guidelines. You have rich in fiber, low in sodium, low in added sugars. You want good vitamins, good minerals. Many of the diets follow that same guideline. On the other hand, it allows us to find all of these other risks, and we have several here in the questionnaire. Some of them allows us to find, and it's part of the rule, what are the risks that predispose for high blood pressure, diabetes, lipidemia. And there's a common recommending known food. Sometimes the patients have not used any of the ones that we recommend. And that part is important. And we're going to talk about this a little bit. And one of the other things that we need to evaluate is the access to food, because sometimes we think that the patient is eating a lot of corned beef or and they don't know how to eat properly, but that not is not necessarily the situation. Maybe they're trying to deal with our finances. Their access is going to determine what we're going to tell our patients. And in the questionnaire, we have the question about how difficult it is to buy food in the last 12 months and if they have any resource available to them. We also have a, a a guide where you can find resources for food assistance, be it community-based or government. And what we tell the patient is also going to be important because we want them to use fruits and vegetables even if they are canned. So we can talk to them about frozen vegetables and fruits, but we have to look then that it's low in sodium. Um, if it's fruits that they come in their own juices, we can talk about seasonal fruits. Maybe the patient has a mango tree in the back of their house, or maybe their neighbor has breadfruit. So when it's a seasonal food, it's easier to find even without a cost. And we can also think about legumes, which we're talking about lentils, chickpeas, beans. We can talk about canned fish as a good source for omegas. So we have other alternatives that can lead them to have a better and a more balanced food habits. And when we're talking about legumes, I want to use some time for that because right now the red meats are so expensive. Eggs are going up and down in price. The same thing happens with chicken and legumes, even when the prices are stable, are very economical. So we have to try legumes as a source of protein and allow the patients to understand that this is a good source of protein. And this is culturally accepted because, of course, everybody here in Puerto Rico likes beans, right? I am pro beans, uh, lentils, you know, all of that is good for you. And if in their institution they have a social worker, we can refer them. And if there's a case manager, also that's a good resource. We have to recommend uh, known food. I'm seeing the chat. And in terms of the known foods, it has to be culturally relevant because sometimes we talk about different types of, grains and stuff. But what do you know that about food? What kind of food you find that are whole foods? Um, what comes to mind immediately for you in terms of cereals, that type of food that are from whole grain, for example? Nobody can think of something. There's nothing in the chat. It doesn't come in mind, but we don't use many whole grains. It's not part of our culture, but we do eat. a lot of uh, other foods, such as root vegetables that are very commonly used in Puerto Rico. So instead of talking about quinoa to a patient that probably doesn't know about that, but yeah, we can talk about maybe they know about whole grain rice, maybe they can use that. The probability that they are going to do that at home, it's not that well, we have to moderate our language. Maybe we want to talk about oats, but maybe we need to talk with a language also about, fat in the abdominal area. We have to go away from all of these very technical language, and we have to look for them to understand what we're saying, make sure. So we have to ask the patient, what did you understand, and what are we going to use from now until the next time that we meet? That's very important. We need to know that they understand, and we want to establish uh, good goals. We want to tell the patient about everything. But this can be confusing and it can be overwhelming, and we have to look at that as something that we don't want. And we have to also know their context. Maybe they have four jobs and they're eating out all the time. And at one of the jobs is where they eat, and maybe what they have available are fried foods. So we have to discuss what's available at their job, what what they can use, what's a better choice, and what they can do when they're at home, maybe in breakfast, maybe how to use or find those vegetables and those fruits. So we have to understand the context. Let's go back to Eduardo. Go back to Eduardo. He eats white rice every single day in all of their foods, all of their in all of their schedule, and it's in high quantities, and his A1C is high, 6.2. So what are we going to tell Eduardo about that rice that he's constantly eating at every hour? Somebody says in the chat to control portions, and we can say, start using less rice. He has to lower carbohydrate ingestion. Maybe the rice has to be whole or quinoa, portion control, and start eating more fiber, or maybe offer carbohydrate alternatives or complex carbohydrates. Those are things that are in the chat. So we are in agreement that he has to change something. Maybe they need, or he needs to use other carbohydrates, but we can't say you're going to have to eat less. That's not enough. We have to give him a guideline. We have to have a SMART goal. And SMART, SMART, is an acronym. And we want it to be specific. S. We can tell him, Eduardo, next time you serve rice, use just 1/4 of the plate. You have to measure it. We're giving him a specific measure. When we're telling him 1/4 of the plate, we're giving him a very specific measure. He has a plate at home, and we know that he uses rice, he eats rice, and we're asking him to moderate the quantity. And that's going to help with the A1C. It's going to be measurable, achievable, relevant, and time bound. We want him to do this for the rest of his life. But we're going to say, no, we're not going to talk about the rest of his life. We're going to say, let's do it until the next time we meet. It's a shorter measure and it's less overwhelming. The other thing that we want to measure is how you're going to follow up on this. Maybe he should He should take a photograph of his plate so that he can show us exactly what he's using in the plate. Maybe if they use an app, My Fitness Pal, or maybe, mark in the calendar how many ways are you complying with this. And we need to see how confident they are about this. Maybe their confidence in how they're going to be able to do this. Maybe it's 5 and one day, and we maybe need to redefine our goal. If it's more than 7, then that means that he's very confident that he can achieve this goal and that this is a good goal for him to go after. And we have to consider other habits. There are other habits that put us at risk, alcohol, smoking, not exercising. So there are other things, management of stress. So we need to also measure all of these things, and we have to consider it in our goals. If he's not doing enough exercise, we could maybe set a goal that they have to do more exercise. And when are we going to refer to another resource? We can refer at any point, but particularly we want to prepare a referral if this patient requires more profound or deeper education, if they have a complex condition or multiple conditions, if the patient is willing and they want to keep learning and they want to keep walking and talking and gets into it, maybe this is a moment that they can go to a nutritionist, or if the patient asks for it, let's take that chance. And we can also think about referrals to case management, social work, maybe to mental health provider, a psychiatrist, a psychologist, a physical therapist, or another specialist, maybe an educator in diabetes, an endocrinologist, cardiologist, any of those professionals. And what about this? This is going to be very important for all the doctors and nurses that are here with us. Why? Because many times we have Don Ramon, they don't know what they're taking, they have no understanding. And when they meet with the nutritionist, they don't have the tools and they have to go fishing to see how they're going to help. Nutritionists, we cannot diagnose medical conditions. So even if they know that they're taking certain medications, we cannot include that information to request anything from the insurance plan. So what I want you to understand is that you have to have all of the codes from the ICD-10 to be able to have the insurance plan cover what we're requesting for that patient. The other thing that could be important could be the reason for referral, if you have labs that are relevant, if there are medications that are related to the condition that we need to take into account, their weight, the BMI, the height, and any other relevant clinical information. This is not an isolated case. There are a lot of patients like them. And what about Margarita? She goes every Sunday to Piñones. She rides her bike, but she eats an alcapurria. She got to our office on Monday because she fell from her bicycle, and she says her left knee is hurting and she's having difficulty walking and a lot of difficulty putting weight on that leg. So, what is the clinical priority at this time? We can see, somebody said pain management. Definitely. This is not the moment to talk to Margarita about her weight. No. Why? Because she's not thinking about that. She's thinking about the fall she had. She wants to know if she has a broken bone. She is consumed by that worry. So these are the situations where we don't want to talk about lifestyle changes. If this is an urgent situation, if there's an overwhelm a patient, if they're in an emotional crisis, maybe Eduardo has a father that had a medical situation. He lost a leg because of uncontrolled diabetes, and now he saw that his A1C is high, and now he's scared. Maybe this is the moment of talking about, yes, this is a risk. Let's talk to our nutritionist about it. I'm going to refer you. If the patient is not open to making changes at that moment, or maybe they're not in agreement with the change we're proposing, maybe Margarita understands that her weight is not a risk for her and she doesn't want to change. And among the first questions, if there's a change in weight, maybe we should include a question about if they feel comfortable, if they would want to change the weight they are at this moment. So, Margarita, maybe we could talk to her about other things, but if she doesn't want to change her weight, that's not the topic because we might be able to gain ground in another way. Maybe we could tell her to start exercising more when she goes to Piñones instead of eating an alcapurria. Maybe she should have a salad with, you know, seafood or something. And what is a good moment when we have routine visits, when it's a new visit or when it's a follow-up visit of somebody that doesn't have an urgent situation, maybe an evaluation of labs when there's a chronic condition with a patient or something has changed when they don't have other priorities at that moment. And if the patient shows interest or is available to change and willing to change. So Margarita comes back after 2 months. She feels good about her knee. There's no pain, and she's ready for changes in her life. So now, what are we going to tell Margarita? What are we going to talk about? Are we not going to say anything to Margarita? We don't know what we're going to tell Margarita. And for that, we're going to get together here tomorrow because we haven't talked about that. Tomorrow is another day, and we're going to dedicate the hour to exactly what should we recommend to patients like Margarita and any other patient that is at risk with their eating habits and with other problems that we might find. Do we have any questions? Do we have any doubts? Do we have any comments? No questions, no doubts? Are you ready for tomorrow? You're looking forward to it? Any difference between nutritionist and dietitian in terms of the specific management? Oh, I lost it. It was a question in the chat. Depending on the case, that's a great question. Yes, definitely. There are nutritionists that are specialized maybe in diabetes or kidney diseases or weight management. Yes, we could identify that specific nutritionist. So the nutritionist and dietitian um, college or association has a list, and they can tell you exactly who is specialist in what. But any could take a first look at a patient. So thank you, Alana. Thank you, Marajeli. And thank you. Oop, I lost the chat. I see so many good feedback. I hope that you're all positive for tomorrow so we can see each other tomorrow at 4 here, right here. And if you have any friend, nurse, doctor that you understand that could benefit from the next presentation, well, invite them because even though we're not going to talk about the specific topics, we're going to speak about others that are as relevant and are as important. Well, thank you so much, uh, Dr. Tirado. You're going to see here our post test. You can fill it out as soon as you are able to. And I'm going to let you see once more the screen. Let's see. Good, great. And you can see the QR code for the test. Next slide, please. You can also go to the polls area. I see that I have some 35 answers, so that is great. That's a good number. And I want to announce that the second part of this webinar, as Dr. Tirado mentioned, we're going to be meeting June 26th for 5 p.m. So register so that you can see what happened with Margarita, our patient. So see what's going on, what's going to happen with her. We have some other announcements to make. The satisfaction poll, you can find it in the chat. Please look at the chat. Please fill it out. That's where it is. We can see it right now in the chat. And I thank you very much to all of you for being with us, and especially to Dr. Tirada for her very important presentation. Thank you so much, and I hope to see you tomorrow at 4 p.m. So invite your friends so that they can benefit from all of this information from Licenciada Gabriela Tirado. For those who are still connected, we have the satisfaction all in the chat, and it always helps us to improve our educational seminars. If not, we're going to be sending it to you through the email, and we will see each other tomorrow. Thank you.